Hi, everybody, and welcome to the Neurocritical Care Society podcast. This is the Hot Topic series. I am your host, Dr. Rich Choi, a neurointensivist at MedStar Health and social media editor for the Neurocritical Care Journal. And before we begin, please note that the views and opinions expressed in this podcast are solely those of the hosts and guests and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. Joining me today is Dr. Katerina Bussel, and we're going to discuss the article Prospective Trial of Cerebrospinal Fluid Filtration after Aneurysmal Subarachnoid Hemorrhage via Lumbar Catheter Extension, also known as the Pillar XT trial. Now, I'm sure that Dr. Bussel is going to be well known to many of you, but for those of you who may not know you, would you mind introducing yourself to our listeners?
Absolutely. Thank you for having me on the podcast. This is very exciting. Nice to meet you all virtually. My name is Katarina Bussel. I'm a neurointensivist at the University of Florida in Gainesville, Florida, where I am the division chief for the Neurocritical Care Division and also a vice chair in the Department of Neurology. And additionally, I do a lot with the Neurocritical Care Society, and one piece of my work is that I am an assistant editor for the Neurocritical Care Journal, which is very exciting to be on the forefront of the very cool, novel, and innovative research that our society puts out.
Absolutely. Thank you so much for joining us. So, this trial dealt specifically with clearing of the CSF space. And so, there's been some recent literature that's been popping out recently that talks about CSF clearance and how it can help to potentially improve outcomes, reduce vasospasm. Would you mind expanding a little bit about our understanding of why we think that this is the case?
Definitely. So it's been recognized for quite a while that red blood cells in the subarachnoid space break down over several days. And while they break down, there has to be a mechanism to clear out some of the breakdown products. It's also been recognized that these breakdown products, releasing hemoglobin and other cytotoxic pro-inflammatory cytokines, for example, are inflammatory and may have a downstream effect, including resulting in delayed cerebral ischemia in the context of subarachnoid hemorrhage, but also in other contexts. And so in the context of subarachnoid hemorrhage, I remember always having trained at the Brigham and Women's Hospital with Dr. Alan Roper, who had been at the time in the 1980s on the forefront of describing, recognizing, and really putting out into very early literature some of the things around subarachnoid hemorrhage and delayed deterioration. He always had mentioned that it had been an observation fairly early on that the more blood there was in the subarachnoid space, the worse it might go in the course of the hospital course. And then with more introduction of CT-based grading of subarachnoid blood, also the recognition that rapid removal or rapid drainage of such blood, or rapid natural clearance for that matter, might fare better. So these observations started early on, and then over the years, literature has accumulated that with draining, may it be through external ventricular drains or lumbar drains, that by removing potentially early removing of red blood cells and the resulting blood byproducts, including hemoglobin, from the cerebrospinal fluid may improve poor outcomes associated with secondary brain injury or delayed cerebral ischemia. And so with starting off with observations, then this formed the hypothesis, which basically resulted in the question, could we help out this drainage? Could we make it faster?
Right, absolutely. Thank you so much for talking about that. And so, what evidence do we have so far that this works? Are there trials out there that have already shown this?
So again, lots of the preliminary data started with observations, right? So removal of blood through external ventricular drains or lumbar drains, but then the most recent and landmark trial is the early drain trial, which was an interventional trial looking at a comparison of lumbar drain or no lumbar drain, in essence, and simplified, in addition to what was the standard of care, which could involve an external ventricular drain or also not. But essentially clearing out CSF in the early course after subarachnoid hemorrhage that was the first trial that resulted in an outcome improvement in the subarachnoid population in many, many years. So definitely a landmark trial and right on this topic that showed that draining might indeed improve outcomes.
And so in that trial specifically, they were basically randomizing patients to having a lumbar drain versus not in patients who already had an external ventricular drain. How is the Pillar XT trial different than what we've seen so far in that landmark trial?
So Pillar, and I'll go back, Pillar XT is the second phase of a trial that was published from the same group in 2019 that was called Pillar. And Pillar XT is basically the extended version of it. So what the concept of it is that knowing that with lumbar drains or external ventricular drains, the drainage rate is somewhat limited, right? You can only turn over so much CSF. And when thinking about lumbar drains, the specific concern always is the downward movement, potentially even the risk of herniation. And if there's systolic crowding, it becomes even more complex. In essence, in most instances, even if it's felt very low risk or no risk, the drain rate is usually limited to at most 10 to 15 cc's per hour of CSF, so limiting the overall amount. And then the idea is was there anything that could be done, a device that could be invented that would essentially wash out the CSF, filtrate it out? I like to think about it as if thinking about a dialysis for the CSF space, basically. So in 2019, the Pillar group did the first in-human feasibility trial investigating very early safety for this device that they call neurophoresis CSF filtration device, and found that it was feasible and, again, very preliminary with a small number of participants at the time, seeing whether this device, consisting of a dual-lumen catheter that needs to be placed under fluoroscopy using an over-the-wire technique, was feasible and would not result in unanticipated or severe safety issues, which it didn't. So then the Pillar XT trial spanned this further and basically applied the same concept, again, introducing this dual-lumen intrathecal catheter into the spinal canal and then filtrating CSF for up to 72 hours in the early phase after aneurysmal rupture or after occurrence of the subarachnoid hemorrhage in the setting of aneurysmal rupture, and then removing thereby blood products from the lumbar cistern, but then reintroducing filtered CSF to the thoracic subarachnoid space. And so that would allow much higher volumes of CSF to be cleaned much faster than it would with conventional draining systems.
Right, absolutely. That makes a lot of sense. If you're returning the CSF after you've filtered it, then you don't have to face the same limitations that you would face otherwise if you're just draining that cerebral spinal fluid out. And just for our listeners who haven't read the paper, I urge you to go to the link and check it out. But in essence, it's placed in the same place where you would put in a lumbar drain, but this gets fed all the way up into the thoracic. And so there would be two lumens, as Dr. Bussel was saying, one through which you would be obtaining the fluid, then filtering it, and then returning it more distally towards the thoracic spine, which I thought was really neat and fascinating. And so what do you make of the results that the authors presented in this paper?
So again, it has to be seen under the context of what this study tried to accomplish, right? So then going back, the very preliminary trial Pillar that looked at very preliminary feasibility addressed this aspect of feasibility and initial safety. So then now this trial would be basically the next step. And when thinking about a next phase trial in phases, would be a phase 2 early phase clinical trial. So they had 29 participants. And as you may imagine, with 29 participants, the number of participants is not large enough to differentiate any outcomes that would be set apart by small percentage points. You will need much higher numbers in later phase trials. So early phase trial, and what they tried to see is a couple of things that were developed further as compared to their first iteration. One of them included a little bit of a longer filtration time, and then smoothing out some of the practical kinks that arguably in a complex trial with an intervention always will come up. So what they focused on was an intermediate outcome, not a finite outcome improvement in the sense that we think about outcome improvement, which would be functional outcome improvement, mortality, or likewise. So they focused on how much could they reduce the red blood cells and the protein measured in the CSF, which makes sense because, again, it shows then can actually the scientific premise be fulfilled by fulfilling the immediate culprit that we think is underlying the issue of blood in the cerebrospinal space. And what they found was that they were able to reduce red blood cells and protein content in essence.
Very neat. And like you're saying, because of the limitations in terms of the outcomes that they were searching, this is probably not ready for prime time. Is that correct?
Now, it is early phase, so there's a variety of things that will have to happen. Of course, this is a complex intervention, so there's always the question, can such a device become readily available? How can this be rolled out to multiple centers? And then again, with a subject participant number of 29 and an intermediary outcome, this is not ready to say, by doing this, we will in fact reach what the ultimate goal is, which is to improve functional outcomes in survivors after aneurysmal subarachnoid hemorrhage. But it is nonetheless promising. So I think what this study sets, and this would be the expected outcome of an early phase clinical trial, is to set data and present the basis to study this further.
Right, absolutely. And I think I'm very excited to hear more about what this group is able to do. But let's say that if they have a larger trial and they're able to demonstrate some benefit, do you see any obstacles that might hinder the ability for other sites to be able to like get on board with deploying this technology?
Yeah, there's always going to be obstacles, right? So with any new paradigms, there will be obstacles. I think with a specific device that is not widely available, purchased, and known how to do it, there is gonna be a bigger hoop as, let's say, to introduce, for example, widespread lumbar drainage. So I think there's two considerations. Number one, of course, this is a specific device, so then that would only make sense to be introduced if future larger scale data, including comparative data, show that this in fact is better than what it is standard of care or what it is existent otherwise. And I think the authors of the paper did really nicely also mention that a future comparison, probably with external ventricular drainage and or lumbar drain, specifically employing a protocol like in the early drain trial, would probably be very valuable. And then if you ask, is there obstacles? For sure. I think if we look around the landscape and even look at editorial comments or practice standards since the early drain trial has been published, I would hypothesize that there are a couple of centers that have introduced this protocolized approach and may now have picked up lumbar drainage, but the majority probably has not. And that has to do with the fact that introducing change and changing paradigms in how care has been done for a long time is always somewhat challenging. It's also very exciting. So I think the challenges set aside, if future data show that this might be valuable, then hopefully people will be willing to look at this as a movement along the spectrum of care that we can offer.
Absolutely. Any other considerations regarding CSF drainage that we should be thinking about as we await more data?
I think what we have not answered yet is the individualization, right? It's gonna be difficult. We don't have limitations like how much blood does one have to have? Might there be a threshold effect? So I think being very astute and observing in your own clinical practice and perhaps looking at individual centers data, perhaps in form of a larger registry, might be profoundly helpful. Because as with many things, there's probably going to be some patients who might benefit from this very drastically, while others might only marginally or not at all benefit from it.
Absolutely. Those are great points that I had certainly not thought about myself. Anything else that you wanted to discuss as we talk about the Pillar XT trial, which is a very, very exciting trial?
I would say to our readership and listenership, I agree with you. I would say go click on the website, read this protocol. It's a short manuscript. It is really concise. It has nice graphics of how the device looks like, and it is a really innovative approach.
Absolutely. Well, thank you so much for joining us, Dr. Bussel, and thank you so much for joining us, listeners. Please find our podcast available for download wherever you regularly get your pods. Podcasts are also available on the Neurocritical Care Society website, and select episodes are eligible for continuing education credits. Don't forget to like and subscribe. Thanks, everybody.
Thank you for having me. Bye-bye.